anatomic and physiologic associations for arrhythmia management. This is a very important topic, joining together advanced imaging and EP. So we'll have our section chief of EP, Luigi Di Biase, introduce him.
Thank you, Leandro, for putting together this Montefiore lecture on CTMR on the YouTube channel. And thank you for having me. Yes, Saman has been, important physician in the field of EP, putting together imaging and arrhythmias. And he has focused his research on cardiac MR, which is becoming more and more important. He was doing a lot of preliminary study at the Johns Hopkins before joining the UPenn University right now. So I'm very happy that he will share with us the relevance of imaging and EP and how the field is expanding a lot. Saman is a good friend of mine, and I'm very happy to have him today introducing his lecture here. And at the end, we will have a few questions from the whole panel. Thank you very much, Saman, for joining us.
My pleasure. Thank you both for your kind introduction and for the nice invitation to be with you today. So I'll talk about the relevance of imaging for EP. These are my disclosures and some funding on the right side. So what's the motivation for this work? Understanding anatomic and physiologic associations is necessary for translation of advanced image guidance to clinical care, and for avoidance of poor outcomes by precise guidance of our more and more destructive ablation technologies that keep coming down the pike. So the objective today is to predominantly focus on electroanatomic, electrophysiologic associations with image-defined anatomic challenges and substrates for reentry. And briefly, I know when we first discussed doing this lecture, you had asked me to talk about MRI in patients with pacemakers and defibrillators. I'll show one brief slide on that as well, and happy to talk about it further in discussions. So to set the stage for what we look for as electrophysiologists in images, let's just talk about cardiac reentry. This was described first in right around in the 1910, 1912 timeframe by George Mines, who's an English electrophysiologist, used to work at McGill, described reentry around an obstacle as a mechanism for arrhythmia in dog cardiac tissue, and described the vulnerable period of the ventricle. And really, his description stands today still as what we believe happens. Sadly, he actually died in 1914 in his 20s. Probably most people think he was conducting essentially EP studies on himself, doing electrical studies when this happened. So the way he described the classical reentry requirements are the presence of an anatomical obstacle and circuit of adequate size. Now, what do we mean by that? That involves the physical size of the circuit and obstacle, the conduction velocity across around the obstacle, and the refractory period of the tissue. And you have to have also unidirectional block so that a reentrant circuit can occur. And this was essentially how he described it. And these are the things we want to look for. Now, by imaging, we can get a pretty good sense of the physical size of the circuit or obstacle and its location. And increasingly, we can get conduction velocity data. And my hope is that through essential experiments over the next 10, 15 years, we'll also get information about the refractory period of the tissue, and that will really inform our efforts to understand which circuits on imaging can support reentry. So I think most of the folks on this talk sound like they're more on the imaging side, and I don't need to really introduce the concepts here, but just in case there are some folks who are not as well tuned with imaging, as well informed with imaging, essentially after contrast injection, we can look at perfusion characteristics, and that tells us quite a lot about the substrate by itself, as we can see in these dark areas with lack of perfusion. And then if we wait and obtain images that are delayed, we can look at the bright areas because the contrast takes longer to wash out of the scar tissue. So of course, these are very useful for us when we're looking for these substrates. Okay, so now how do we use this for VT? This is an image that the electrophysiologist will be familiar. This is from one of the software companies that has really championed this work. And again, as a disclosure, I consult for them and have research grants from ADAS software. But there are others available that can show us this type of anatomic rendition and segmentation that we can bring into the lab. So years ago, when we first started doing this work, my interest was in taking points that we have touched in the ventricle and superimposing them with the image so that we could then process the data, use statistics to figure out what we can glean from the associations from the electrograms with specific portions in the image. Now, over time, our sampling density has increased significantly with the availability of multipolar catheters. And I'll show you more data as we go through. But the basics of how we did this work back in the 2010 sort of era, a decade ago, is that you have to do the analysis properly. If we just pull data, say in this example from one patient and the second patient, and say you have voltage on one axis and the intensity of the image on the other axis, and you pull them all together, you may get one slope. But you really have to, when you're analyzing this type of data, take into account Simpson's paradox and take into account the interpatient variations that are going to affect your model if you pull the data together. So you can end up with very different slopes if you cluster the model or not. So that's very important. And when we do that, what we find are significant associations between the points that we touch, the electrograms that we sample locally, with the image characteristics at that point. So what we find is that all the electrogram characteristics, bipolar and unipolar, most commonly used, voltage, duration, which I think is exceedingly helpful, number of deflections, which if you think about it, is essentially ILAM. ILAM describes duration and deflection. It's just another way of saying the same thing. If you take your cursor to the end of the signal and it's a long signal, compared to other signals, you're going to see those. Those all correspond significantly with wall thickness. Here, I'm not talking about scar thickness, the viable wall thickness. And that makes sense. The same scar will have different electrogram characteristics, the same scar width, the same scar mass, depending on how much surviving tissue is next to it in the same voxel. So not all scars will be assessed the same. It's really hypertrophy, the cardiac remodeling that comes with scar, that affects our electrogram characteristics. But you also do have to take into account the scar thickness and its intramural location with respect to that left ventricular hypertrophy. And of course, with the electrogram duration, which will affect our assessment of ILAM these days, the terminology we like to talk about, you have to consider antiarrhythmic drug use because it will significantly affect electrogram duration. Okay, so now in electrophysiology, we are very interested in circuit sites. We want to know that when we perform entrainment in a patient with usually stable VT, but sometimes even unstable VT if we do it quickly or with hemodynamic support, we want to know what these sites correspond to. I want to know how they correspond to scar transmurality. So if we look in ischemic cardiomyopathy in a cohort of patients where we had stable reentry and concealed entrainment with a short post-pacing interval. So these are all, each of these dots is a critical VT circuit site. And we map the correlation, or we look at the correlation of the stim to QRS over VT cycle length which is a measure of where within the circuit it is with scar transmurality, we find something very interesting here. So if the stem to QRS divided by VT cycle length is short, and we usually call that less than 30% in EP, we're at an exit site. So if you look at all these sites with less than 30%, here's this horizontal line. You can see my mouse, I hope. Less than 30% stem to QRS divided by VT cycle length. We see that they're mostly in 25% or more scar transmurality regions. You can't have those exit sites in sites where there is no scar. If you pace in sites where there is no scar, you're not going to have truly concealed entrainment. You're not going to have a short PPI. So short post-pace interval, concealed entrainment, and exit site features in sites with greater than 25% transmurality. Now here's the part of real interest to us, because in EP we like those central circuit sites. Why do we like them? Because they tend to be narrower. 1 or 2 lesions will take care of the job, whereas exit sites tend to be broader. If we ablate here, we may need to ablate all the way over here, and then we may not even terminate the VT because it could find another exit site. So we like these central isthmus sites. And if we want to see where these central isthmus sites are, so sites where we pace, we have the perfect morphology of VT. That's what we call concealed entrainment. And we have a short post-pacing interval, meaning the time it takes the reentrant beat to come back to our catheter is the same as it takes for the VT circuit to propagate. If we look at those sites and select the ones that have 30 to 70% stem to QRS over VT cycle length, which signifies the ones that are in the central isthmus site. I think this is really important. These sites are confined. Look at this graph from our publication. I think it was 2013. They're confined to regions with greater than 75% scar transmurality. So if you have your MRI and you know which parts have more than 75% scar, and you just go and sample those sites during your entrainment maneuver, you're going to find the central isthmus sites in those regions. And that's really valuable to us in AP. How can we make this even better? Well, when we wrote that publication in 2013, I think it was Circ A&E. Sorry, the reference is not down at the bottom, but hopefully it'll come up at the other ones if you want to look at it on the other slides. We were using 2-dimensional imaging. So our in-plane resolution was not that high. And so back then, when I would segment the scar to bring it to the lab, this is what it looked like. I would do 100% or 75% and more transmural scar as gray. I would do the normal myocardium as blue. You can see there's, it's got the stepwise features of 2-dimensional imaging that are about 8 millimeters thick. And then I would sometimes segment the ICD lead just so it could help me register the image well to our mapping system. And then I would correlate to isolated potentials within that transmural scar. Often you would find the channel with electrogram mapping, but wouldn't see anything with imaging. Still won't see anything with imaging if you're using 2D imaging. And then start to go fishing in those regions. And in these regions in the transmural scar, we would once in a while find these nice features and pace and find a short return like I was describing in the prior slide, and ablate and see the termination of the VT. So we would have to hunt this whole 100% or 75% and more transmural scar to find the good regions. Now, over time, our imaging resolution has improved and the software technologies have also improved. And so now there's software available where we can localize even channels inside the scar. Now, often the software will find a lot of channels and only some of them correspond to the VTs. You can see in this patient that I took to the lab, this one was perfect for this VT. You can see these isolated potentials occurring during the diastolic period of the VT, and the pacing features are favorable for those of us in EP, and we ablated here and we terminated it. But this channel didn't have anything. I ablated it anyway because it may support VT in the future. And so the channels, I think, are sensitive. They're not necessarily specific. Whether you should ablate all of them or not, to be determined in the future. But certainly this gives us a good method to proceed for finding the sites that are favorable. It does not mean we should not do normal EP maneuvers. I still do all the entrainment maneuvers, and you want to find the perfect sites with the old maneuvers that we know and love. But as Luigi knows, as his publications have shown, we deal with VTs that we can't map all the time. You know, we have these big scar substrates, and sometimes substrate modification is helpful. And in those situations in particular, having an image like this is exceedingly helpful, because substrate modification may not hit the whole scar if the scar is non-ischemic. These are examples of ischemic cardiomyopathy and data from ischemic cardiomyopathy. Now I'll show some non-ischemic cardiomyopathy in the next few slides. A quick word about fat metaplasia. This is something that I've grown to love and develop a lot of interest for. I didn't really appreciate until maybe 2013, 2014, that a lot of the ischemic cardiomyopathies that we were dealing with actually had a lot of fat metaplasia in the myocardium. I'm not talking about around the heart. In the myocardium, within the scar, if you look at the pathology, there's areas of muscle, there's areas of scar, there's areas of fat inside the myocardium. And on CT, we can see these. And what we've more and more started to realize is that a lot of these isolated potentials that we're hunting for are within areas of fat. And that makes sense because fat is a very good insulator and can protect the inner circuitry of the VT. Now, you may say, I've never seen that before. And I want to show you this image. Look at this. This is, and I would imagine the ones that say I've never seen that before would be more likely to be EP. Probably the imaging folks in the audience have seen this all the time. You get a CMR of one patient and you see all this delayed enhancement. And in our publications and in our daily life, we sort of talk about this just as scar. It's not all scar. If then you get a CT and put a mask over the intensities that have to be fat, what you realize is that a substantial amount of this delayed enhancement is actually fat. So we really don't know when we look at an MR and we just call it scar, whether it's fat or scar or maybe even inflammation. Parts of this could be inflammation. We don't know. And maybe it doesn't matter when we're ablating, but I think it does because A, the fat seems to associate very closely with VT sites, and B, the fat probably affects how well we can ablate that tissue, because our ablation methodologies, at least up to now, depend very much, for the most part, on the impedance, the sink that we're pouring these electrons into, and fat is going to have very different impedance characteristics and ability to take the current. So here's some data showing one VT that goes through this extensive fat deposition and very favorable circuit characteristics, again, going right through the fat. And we've started to focus on this. My NIH grant at the moment is focusing on fat deposition, and we'll have more to come on this as we develop more and more data. Now, CT can also be exceedingly helpful, not just because of the identification of the fat, but because you can use contrast enhanced CT, look at the perfusion characteristics, as I showed with the MR slide, but just similar methodology. And you can also use delayed enhanced CT. Now, in ischemic cardiomyopathy with the dense scar, I find delayed enhancement works well. In other types of cardiomyopathies, you may have to use wall thickness or perfusion characteristics. And I think the SNR is an issue. I think everyone knows this. It becomes a little bit less specific. But we've used this methodology to identify scar, and we can even see what the field of view of our catheters is based on correlating the electrogram information to different voxel sizes or different radiuses of analysis. What we can gather is that the antenna for a 1 millimeter electrode with 4 millimeter interelectrode spacing in our study Penarray was 5 millimeters versus the standard mapping catheter that we tend to use, the STSF catheter, is 15 millimeters. So that really tells us about the radius of tissue that we're sampling each time we touch. And the fact that since most of the time we're using these catheters, depending on the software system or the mapping system we're using, we really don't have a ton of information. Our sampling density is not very high, and integration of images can provide quite a lot of data that can complement our assessment. We can also examine the association of conduction velocity with image attenuation on CT. So in this study, we looked at the local conduction velocity and compared it with attenuation and found a very close association. And this is part of what I had mentioned earlier, that when we look at reentry, the size of the circuit is important. And there's all sorts of simulations being done to predict who is going to be at risk for VT and predict ablation sites. And a lot of it is theoretical. We don't really know what the conduction velocity of certain image characteristics will be, certain myocardial segments with certain image characteristics will be. And we need a lot of work to refine these findings before we can do accurate simulation studies. And conduction velocity is just one bit of the puzzle. We don't know the ERPs of the tissue and action potential duration. So I think those are all things that we need to really dissect before we can hang a lot of weight on simulation-based approaches. Now, to talk briefly about non-ischemic cardiomyopathy, the data I showed previously was all ischemic cardiomyopathy. In non-ischemic cardiomyopathy, we of course have a lot of different types of substrates. We have different locations within the wall, and then we have these patchy scars that sort of go from the endo to the epicardium. And if you look at the distribution, they're all quite common, and with exception of transmural, which is pretty rare in non-ischemic cardiomyopathy, you can see all sorts of different distributions. If you look at the association of LGE with various voltage measurements, bipolar is what we tend to use for ischemic cardiomyopathy. And as you can see with non-ischemic cardiomyopathy, the issue is the association varies depending on which type of scar you have, and you would expect that. If it's deep in the myocardium, bipolar voltage, because it has a shorter antenna, will not detect it very well. Unipolar voltage has worked reasonably well, but you can see again, there can be quite a bit of variation depending on whether it's endocardial versus midwall or has other intramural locations. What I've found based on the imaging work is that electrogram duration is actually a very accurate surrogate of scar location as well. You can see actually the extent of variance due to location of the scar is much lower when you're looking at electrogram duration. So if you look at electrogram duration greater than 100 milliseconds, you really you have a very good chance of finding regions that have scar. And I think this can be very handy when working with non-ischemic cardiomyopathy. If you look at our data and what are the best cut points based on standard AUC criteria. So the C statistic is maximized where we have sensitivity and specificity weighed equivalently. A bipolar voltage of less than 1.8 is great for non-ischemic cardiomyopathy. Unipolar less than 5.6. Now this differs from work previously published at my institution at UPenn, in that here we tend to favor unipolar voltage cutoff of less than 8.3. And the reason for that is, remember, I said this is based on finding the best C statistic, meaning optimizing both sensitivity and specificity. Now, when we're in the lab and we're working hard to find circuit sites for 7 different inducible VTs in a non-ischemic cardiomyopathy patient, we tend to care less about specificity and we want to maximize sensitivity. And if you look at the data, what you find is that 8.3 really does maximize sensitivity, but we have to bear in mind that the specificity is much lower. So it's 65.7%. So, I tend to use that when I'm trying to find the circuit sites, but you have to, if it's a patient with EF of 10% and we're not very specific and we just ablate everything with voltage threshold less than 8.3 in non-ischemic cardiomyopathy, we're going to ablate a lot of innocent bystander myocardium. So I think you have to weigh it in the balance. What's their EF? How much Are we going to affect their EF? I've had patients that have had worse heart failure after VT ablation. Certainly, I know I have. And I think it's a difficult balance when we're doing this kind of ablation. Now, electrogram duration, that's why I like it a lot, because the specificity is 84%, still with a very good sensitivity. So I wish software would give us, I wish our electroanatomic mapping software would give us electrogram duration. I've been advocating for this, and I just don't have their ear enough to get it. But I think eventually we'll have electrogram duration, and I think a cutoff of 100 milliseconds will serve us well. Now, if we look at the critical sites in non-ischemic cardiomyopathy, it's a little bit more difficult. Here, I'm not showing you stem to QRS over VT cycle length because we didn't have as many chances to entrain the VT. These are fast VTs. These patients are crashing. We didn't have a whole lot of them back when we did this in 2013. We weren't doing a whole lot of hemodynamic support VTs. And so I just used stem to QRS as a surrogate of sort of slow conduction. And what you do find in these sites is that they tend to be, again, either greater than 75% scar transmurality or patchy scar. So these patchy regions that extend from endo to epi or pretty transmural scar, those are good sites to go hunting for non-ischemic cardiomyopathy. Interestingly, late potentials or lava are actually far less common in non-ischemic cardiomyopathy, as the EP folks in the audience know. But when they're there, they tend to be in more non-transmural regions of the scar, and they don't tend to be but based on our retrospective analyses of these images and electrograms in regions of critical VT circuitry. The regions with more scar that have less prevalent late potentials and lava are actually tend to be more important. And this is something I want to highlight. In the non-ischemic cardiomyopathy group, of all the critical VT sites, about 20% were located in adjacent regions adjacent to late gadolinium enhancement, but normal bipolar and unipolar voltage. So you have to keep an open mind that the bipolar and unipolar voltage will not find the right place, and keep searching. And I think this data that we just published in JCEP, actually, I can't recall. Luigi, you may have been the associate editor for this paper. I can't recall. I think you may have been. I think this helps. If you look at patients with dilated cardiomyopathy and look at all the image processing on the side here and the sites that were critical sites, what you find is that 88% are in the dense scar, 3% in sort of the border zone of that scar, and 9% in healthy tissue, but within a centimeter of that scar. So really, you can keep searching there. But the more important part is that in idiopathic VT, idiopathic dilated cardiomyopathy cases with VT, not sarcoid cases, because we had those in this series too, but in the idiopathic dilated cardiomyopathy cases, all of them were confined, all the critical sites were confined to regions right next to the valves, within 2 centimeters of the aortic valve and essentially within 2 centimeters of the mitral valve. So if you see scar and you see it close to a valve, you go right in between that scar and that valve, and that's where the fishing is the best. Sarcoidosis, no, doesn't have to be near the valves. It could be anywhere within that scar. And I find this to be very helpful when I'm taking care of my non-ischemic patients. Now, a quick word about ARVC. We can use images for ARVC as well. These really can't be 2D images. They have to be high resolution 3D images. What we've started to do is develop standardized Z-scores for these, because otherwise it's hard to analyze the thin tissue, and there aren't good methodologies for identifying scar. You know, it hasn't been worked out in ARVC like it has for ischemic cardiomyopathy, where you say, you know, 2 or 3 standard deviation above normal myocardium or full width half mass and so on. So we developed Z-scores, correlated them to the bipolar voltage on epicardial mapping, and here are the cutoffs, and you're welcome to use them if you can you know, convert to z-scores. The problem with MR, as everyone in the imaging in the audience knows, is the arbitrary units, and that's why we convert them to z-scores, because it makes it much more comparable from patient to patient. So if you convert to z-scores and then use these cutoffs, you end up with segmentations that look pretty similar to your actual epicardially mapped voltage, and these late potentials tend to be confined to the regions based on these cutoffs. So why is that helpful? Because actually the group in Bordeaux has shown, you don't have to be on the epicardium to ablate ARVC. It's very easy to dissociate the epicardium from the endocardium. While you're ablating from the endocardium, dissociate a part of the epicardium. The wall is thin. The problem is the mapping. So if you know where the substrate is based on MRI, you really don't have to go to the epicardium in ARVC. And I can show you that in this case where I was doing this just to prove this point. So I'm going to play this video in a second, but look at here. This is the pen array catheter, multipolar catheter. I have this parked on the epicardium adjacent to this scar. And then on the inside, going through the tricuspid valve, is the ablation catheter. And I've started up top and ablated and kind of come around, and you can see there's a gap here. And I'm just ablating this last part. Now, when I play the video, look at the electrograms. You're seeing electrograms on the pen array on the outside. These are delayed electrograms showing you that it's mostly diseased, but still communicating to the paced beat on the surface, delayed. And then as I ablate here, you can see that ablating on the endocardium will all of a sudden dissociate, completely silent, turn off the lights in that region of the heart. So you don't have to be on the epicardium to do this. All you need is a good image, and you can find that substrate and ablate it from the endocardium. Now, you had asked me to talk about MR in patients with cardiac devices. I've not focused on this for some years. 2017 was our last publication on this. And so I thought I would just summarize that publication, which was our biggest on this topic, where we enrolled 1,500 patients while I was at Hopkins. 58% of them had a pacemaker, 42% had a defibrillator. These were all legacy devices. They're more conditional devices we did without the same rigor. There were, of course, many more exams because many patients had more than one. They were all clinically necessary. Essentially, it's fairly simple protocol. We changed the pacing mode to asynchronous for those that were pacer dependent, to demand mode for others. If I was doing a cardiac MRI, I tended to keep them actually asynchronous, even if they weren't pacer dependent, because it goes faster. You're triggering by the pacing, and you can just crank up the rate to 80 or 90 and do the image much quicker and with less artifact. And you disable the tachyarrhythmia functions, including the monitoring, just so you don't waste battery. And we looked at their adverse events and outcomes, and essentially we really didn't have anything clinically significant, either long-term or short-term, with exception of one event that I'll tell you in the short term. So long-term, no significant clinically adverse events. Short-term, we had 9 exams where we had a power on reset. So this is something that tends to happen in older devices, and also when the devices are approaching ERI. So I used to say, as they're approaching ERI, let's just do the scan, because if we're going to damage it, we're going to be replacing the device soon. But the problem with that is they tend to be more likely to have power on reset. Now, what happens with a power on reset? If you have a pacemaker, you'll go to ventricular inhibited mode, and the problem with that is if they're dependent, then they won't be pacing. So you're watching them, and you can pull them out and they'll start pacing. It'll be okay, but you have to make sure somebody is watching them. And then the other problem is that if it's a defibrillator, the tachycardia therapies will turn back on. Now, it's not going to shock the patient, because the transformer won't work in the magnet. It won't actually be able to charge up to voltage and deliver the shock. But that can then lead to a worse problem with the generator and drain the battery completely. So it's better not to do the exam if they're really getting close to the elective replacement interval of the battery. But for the most part, this is very rare. 0.4% of our patients had a power on reset, and all of them were transient. We could reprogram the device afterwards, and nothing untoward happened because we were watching the monitor, and there was no significant inhibiting of any pacing because the exam was stopped. One of them was not transient. This was a patient with less than 1 month of battery life, and we just couldn't reprogram the device, so we had to replace it. But as you can see, it was due to be replaced anyway. So we didn't have any significant, even short-term issues. And long-term, I mentioned no adverse effects. There were some changes. You can see changes in device parameters, and it's hard to know truly are these real or not, because we see if you take a patient and measure their P wave amplitude now and then in an hour, or their impedance now and then in an hour, you see some variations, and it's hard to know. But we did have some decrease in P wave amplitude, which occurred in 1% of the patients. And at long-term follow-up, of course, there were some changes. And again, it's hard to know if they were related to the progressive changes in lead parameters that we see in patients versus anything attributable to MRI. But none of them were significant enough to warrant device changes. I think maybe even reprogramming was quite rare, if at all. So that was my slide on device imaging devices. I'm delighted to talk about that more. I think we have about 20 minutes left, so I'm going to go through AFib fairly quickly as well and leave some time for questions. So everyone's familiar in AP with the normal pulmonary vein anatomy, and we could almost draw these lines with our eyes closed. Certainly without fluoroscopy at this point with our mapping systems and intracardiac echo. But it's good to have imaging beforehand. You tend to see quite a lot of variations. Here's my most strange, I think, variation, where it seemed like the patient must have a lung next to their spine with a vein coming straight off the back. And cardiac CT is extremely helpful, and MRI is also extremely helpful. And with MRI, the advantage is you don't add any radiation to the patient. And I'm just showing this slide to show that, ICE, we talk about ICE, we'll see all the variations in anatomy anyhow. Why do we need pre-procedural imaging? Here's the ICE. I've started to use the ICE in the left atrium, and I think it can be helpful. You can appreciate that in the left atrium, our views would be the best. And here's the problem. I think that the field of view is so small that you can see certainly the right inferior pulmonary vein very well here. But, would I appreciate this branch next to the right superior as I'm coming up here? I don't know that I would have. I think having the image and of course, the FAM map as well helps. The other thing that it helps is you can segment the esophagus. Here you can see the esophagus segmented, and it correlates beautifully to the esophagus seen on ICE here right behind it. And I can see, even when I'm next to it, my association with the esophagus, which I may not see on ICE when it slips a little bit rightward here. So I think image segmentation and registration helps. We've come a long way with our software and with intracardiac echo, but I still think there's a role for it. And then, of course, just reviewing the anatomy for each patient is exceedingly important, so that we know, depending on the circuitry we're chasing after, can we reach it from the epicardium? Are there reflections that are not going to allow us to reach that space from the epicardium? Would the CS help? All these relationships are extremely easy to appreciate when you look at a three-dimensional image or a segmented image, and not so easy to appreciate when you're just looking at a small portion with intracardiac echo, or some people not even using intracardiac echo in Europe. So I think image segmentation does help. Now, beyond that, does it help us with the substrate? So we know that in patients without AF compared to those with AF, there are differences. In those patients with AF have more disarray and myocyte hypertrophy and more interstitial fibrosis and reduced capillary density. And if we get an image of a patient with AFib, we have to make sure it's a 3D image. And it wasn't until this image. This was a patient that I'd done, or actually, it was one of my colleagues had done a laser ablation. And I think with laser, you really see the area presumed fibrosis very well. And this seems to be the characteristic also with pulse field ablation that's coming out. And so once I saw this image, I became a believer that we're seeing something real. But the resolution is tough. You know, you really have to work to make sure you're contouring the wall, and how do you threshold the image appropriately is important. And this is, as you can see, a bright blood image. There are dark blood sequences available. We don't have a 3D sequence. We have a 2D sequence. And I think developing a 3D dark blood sequence is a challenge. I would love to get my hands on it, but it's a challenge. There are a lot of challenges that go into that. So we can talk about that further if needed, but we're currently using bright blood images, and that makes the segmentation a little bit harder. This is the sequence we use. So it's 1.25 by 1.25 and 2 millimeter slice thickness. So the resolution could certainly be better, right? Because the atrial wall at some points is less than 1 millimeter thick, and volume averaging is an issue. Now, Nasir has shown that left atrial scar, as defined by their software, correlates with clinical outcomes. This was a beautiful paper in JAMA where they showed that with 272 patients that had undergone ablation, the extent of scar correlated very closely with how they did post-ablation. And we have similar data as well that I may be showing a little bit later. But here are the challenges. I mentioned the 1 millimeter thickness, and our resolution is just not high enough to say this with certainty. And when you look at the diagnostic performance of LG versus bipolar mapping, it's not great. The positive predictive value is 0.8, negative predictive value is 0.7, sensitivity of 0.8, specificity pretty low at 0.7, just about. And well, you could say, well, bipolar voltage is not accurate, but I don't know what surrogate to use for scar in the atrium. So we decided to normalize the image intensity and see if that would help. I talked about normalization a little bit earlier. In this case, we use this measure image intensity ratio that's now available in some commercial software. I wish I had patented it. But we've moved on actually since then to Z-scores, which I think perform better. But the image intensity ratio also performs pretty well. You can see the confidence intervals are decreasing with accruing patients, and you can estimate our typical voltage thresholds. I tend to use the less than 0.1. They estimate those thresholds pretty well. And if we use those and estimate scar, what you find is very similar results to DCAF1, where if we have patients with greater than 35% scar transmurality, they tend to do worse, hazard ratio above 1 post-ablation. And what's interesting is that regardless of whether they're persistent AF or paroxysmal AF, the outcome is determined by the amount of scar. So if you have a persistent AF patient with less scar, they do better with ablation. They do just as well as the paroxysmal AF patients without scar. And so it is a good way, I think, to select patients. But can it guide the ablation? Say you have a patient that underwent ablation and is having more AFib. Can we figure out where the gap is based on LGE? And the Peters group, actually, Dana Peters was the first patient to image the atrium using delayed enhancement, and they published that they can see gaps. And this was when Dr. Josephson was part of this study, and that it correlated actually with recurrences. If the RIPV had gaps on MRI, there was more likely to be recurrences. And I think that's very interesting and could be part of our armamentarium, but I think it's tough to do it. I mean, again, the wall thickness drops significantly around the pulmonary veins, and then there's differences in the tissue, in the myocardial extension into the pulmonary veins. So you would expect to see some areas of delayed enhancement that are just delayed enhancement of the vein. Because there's no myocardial tissue. And if the image plane is cutting at a slant where it's looking at that area, I might say that, well, that's isolated. But if it had cut through this area with the myocardium, you would not appreciate that. So I think you would have to select your angles perfectly to the regions where you actually drew your ablation lines to assess it. You can appreciate that here too. The left superior has a lot more myocardial extensions than the left inferior, and so on. So where does targeting LGE stand at this point? Now, you could target LGE to close gaps in the veins, or you could just say, if there is LGE, I should ablate it. And it may be true. The studies so far are a wash. These are actually from the same group. One retrospective, where they took 35 patients undergoing redo AFib ablation and performed MR, and then targeted those regions with gaps as well as the regions of delayed enhancement. And the conventional group did worse than the LGE targeted group. And then they did another study where they randomized patients and there was no difference. Now, the downside of this study was a lot of the patients had no fibrosis outside of the veins. So, you know, does MR help in patients without fibrosis outside the veins? Probably not, right? Because there's nothing to target beyond the veins. So I think if half of your patients don't have any additional targets on MR, you probably don't have the power to see it. So we really have to wait for DCAF2. I don't know what the results are going to be. I think there are pros for targeting LGE, and that we know from our work that conduction velocity is reduced in regions with more intensity, ergo more LGE. And so if conduction velocity is reduced, then there's more likelihood that regions with low conduction velocity will support reentry, then targeting them would potentially help. But then it's hard to tell the difference between LGE that's from ablation versus pre-existing. There's slight differences, but you can see there's a lot of overlap as far as the image intensity and wall thickness. So how do you know? Are you just targeting regions that you have ablated before in a redo patient? It's hard to know. And most of the ones with LGE are patients that have had prior ablation. In patients that don't have prior ablation, have never had prior ablation, the LGE region is often normal on bipolar voltage, but it shows fractionation. So what does that mean? Is that just where the fat pads sit? We know that regions with ganglionic plexi and fat pads tend to have more fractionation. Is it regions with, where the septopulmonary bundle or other epicardial bundles are crossing? I don't know. I don't know if they're scar. I don't know if they're corresponding to epicardial fat pads. And I think there's a lot more to be learned before we start birding the LGE regions. But certainly DCAF2 will provide us a lot of data in this regard. I'll skip over some of these slides in the interest of time so we can talk more. The left atrial endo-epi disconnect is, of course, something that's of interest to all electrophysiologists at this point. There's some beautiful data coming from both UCSF and from Rod Tung in Chicago. Here's a patient that I had where I had done a PVI and a posterior wall ablation before, and she came back, and really on the posterior wall endo, I didn't have a whole lot of signals. But epicardially, and on the endo map, it looked like just a breakthrough, and I couldn't find any good post-pace intervals endocardially. On the epicardial map, it took me 45 minutes to get the pen array in the back here, but once I had it, the whole cycle length was there, and a short PPI. And I wasn't brave enough to ablate on the epicardium, but I came on the endo directly opposite to that region where we seem to have the great post-pace interval and most of the cycle length, and ablation there terminated the attack where there was not much signal on the endocardium. So I think there's more about this anatomy that we need to ascertain, and with improved imaging, we may be able to understand it better, but we need a lot more imaging power to be able to see that. There's uneven thickness in the atrium, and that's being taken advantage by a study from Antonio Barroza, where we're going to target regions, the ablation index based on the wall thickness and distance from esophagus, and I think that'll help. We're doing a lot of work on esophagus as well, and finding some interesting data that essentially the baseline impedance, if you correct for distance from esophagus and force and other variables, the baseline impedance is very strongly associated with esophageal heating. And I think we need to look into that further as well. Now, let's see if I can finish in 5 minutes so we have time for discussion, and maybe even less than 5 minutes. A quick word about functional MR. You can also do functional CT, but it provides a lot more radiation. I find that functional MR and doing strain analysis finds regions of scar very well. We've shown that previously, that it correlates with the I should call it LGE, regions of LGE, but it's actually more reproducible. It's easier to assess strain for these images now with the advanced software. And we know that persistent AF is associated with reduced passive EF, reduced strain, both peak global strain and all the strain rates. And it's importantly, the odds of cardioembolic stroke are higher in those with worse function as assessed by strain rate, and lower in patients with better reservoir function and higher active EF. These are important. I think these should be part of our CHA2DS2-VASc scoring system or the expanded scoring system in the future. And it's also important for us because when we looked at our data, the extent of fibrosis that we lay down post-ablation is associated with the total LAAF. And so if you extrapolate from this, we're potentially increasing the risk of stroke for some patients where we do extensive ablation outside of the pulmonary veins. And I think probably understanding the effect of our ablations on strain and strain rate is going to be important in the future. So I'll stop here. In summary, I think image-based arrhythmia substrate assessment is very promising for us to sort of more precisely target our ablations and more precisely assess the effect of our ablations. In the setting of classical reentry, it's sort of a no-brainer that if we can see the scar, we can at least find the areas where we should go fishing. And I hope with improved understanding of what the conduction velocity characteristics and ERP characteristics in each region, depending on intensity of the image, we'll have even better modeling and patient selection strategies. And in functional reentry, I think it's work in progress. Much of it depends on how quickly we can improve the resolution and reproducibility of the images, and when we understand what LGE in the atrium really means. And I think we really need to have that before we apply it to therapeutics, but it's applicable for patient selection. So thank you for your attention. Thanks again for inviting me. Really delighted to be with you, and I look forward to discussing these topics.
Thank you very much. That was an outstanding lecture. I think both for the EP people and for imaging, this is an amazing area. So I'll let now the questions come, and Dr. DiBiase that will lead the questions as well. I just want to start with one. I think obviously we have a lot of patients that go for ablation, a lot here, but probably everywhere as well. So what patients do you send for MRI? What patients do you choose to do CT, or do you do both for everyone from a clinical perspective more than research?
Yeah, for clinical, from a clinical standpoint, I think it's exceedingly helpful for patients with non-ischemic cardiomyopathy. And I think here we try to get everyone to the scanner. You know, if it's somebody who comes in with VT storm and they're unstable, of course, we're not going to be able to scan them. But you know, if it's someone who's stable, whether they have ischemic cardiomyopathy or non-ischemic cardiomyopathy, we try to get an MR. I'm getting CTs on a lot of patients because of my interest in the fat metaplasia. But essential for clinical practice, I think in non-ischemic cardiomyopathy, it really is essential because our methods to find scar in some patients are just not enough in the AP lab and are significantly helped by having a better understanding of the substrate. Now in AFib, I like having an image. Is it necessary? No, you know, like just this morning, my assistant called and said, yeah, I have a gap. Can I put this AFib? I won't be able to get the image. And absolutely, no, I'll happily do it without the image. But I think it's helpful for the pulmonary vein variations. And I think it's particularly helpful in redo patients because we want to make sure that there was no stenosis from the prior ablation. So I think, in short, that I think non-ischemic cardiomyopathy is really where it helps.
Saman, thank you so much. I have a question for you, and then Dr. Romero will have a question for you, and I'm willing to receive questions from the audience. So for AFib ablation, there is controversy a little bit about the definition of what is scar, meaning the Marouche interpretation of scar is, you know, personal definition of you know, how to define the scar. There are, if I look at the literature, and you know, the pre-procedural scar on MRI looks to me almost as subjective as an ejection fraction on the echo.
Maybe more.
34, for you is 37, for somebody
Yeah.
else it's 39, and the identification of this scar in pre-procedural MRI is variable. But if that has the one that guides the ablation procedure, it kind of, you know, worry me. What is your take on that?
Yeah, I absolutely agree with you. I think that's why we started standardizing the image intensity and sort of trying to develop thresholds for it, because I find the same problem. And it's not just the thresholds, it's also contouring the myocardium is very difficult. It takes an experienced person. And even then, depending on the quality of the image, it can be very difficult. So I personally don't think targeting LG at this point makes sense. You know, I think we'll see what DCAP 2 shows, but for me, I analyze the LGE for research purposes. I look at the electrogram associations with it because I want to learn more. And I also, because I have other hypotheses, you know, I don't think all the LGE is scar, like you said. I think some of it is probably inflammation. Some of it is fat pads tend to accentuate that region of LGE because of MR, technical MR issues that I don't fully understand. Proximity to the aorta does the same thing. Slow blood flow in some of the pulmonary veins, particularly the right superior pulmonary vein, will accentuate, sort of give you a higher image signal. And then some of it, honestly, my hypothesis is the fiber interactions. I think that where the fiber directions change, you tend to see some LGE. I don't know yet why. I think that'll be very interesting to examine. So I agree with you. At this point, it's not my practice to target LGE. Even when I see low voltage in a new patient, I don't necessarily target it. I don't know if you do that. You know, in a new patient with AFib, when I see low voltage, you know, I'll certainly go looking if they have atrial flutter and an atypical AT there, but I won't necessarily target it. So I fully agree with you. I think that's a great comment.
We have a question related to this. Congratulations on your presentation from Kana here. I believe LGE is overestimated soon after ablation. How long do you recommend to wait after ablation to evaluate extent of LGE in the left atrium?
Yeah, that's a great comment too. I think so. You can see the left atrial wall thickness is accentuated after ablation if you immediately image it, and you can see that best on T2 images. And the extent of LGE is greatly over exaggerated. And in animal models, even touching the tissue with catheter will cause LGE. You don't even have to ablate. So the parts that are probably going to become true LGE later on at 3 months or 6 months later, I think 3 months is probably enough, are the microvascular obstruction parts. So you could look at the microvascular obstruction extent. That'll probably underestimate it. But yeah, that's a great point. We don't usually re-image within the first 3 months.
Let's switch gears now on device. Before we switch gears to device only, does previous antiarrhythmic therapy influence any of the imaging parameters in patients with ischemic or non-ischemic cardiomyopathy?
That's an interesting question. I don't think so. I think that, you know, if you're doing
and this question came from Dr. Ferrick.
Yeah, I think if you're doing a CT scan, you want the heart rate to be lower, of course, and so it's helpful to keep the antiarrhythmic on board. If you're doing an MR, a faster heart rate doesn't matter so much. Arrhythmia does. So in general, I tend to keep the antiarrhythmic for both imaging types. If I have a device and I'm doing a cardiac MR, I tend to speed up the heart rate, take out some of the effect of PVCs and PACs by going a little bit faster, make the scan go faster. But no, I don't think the antiarrhythmic by itself should affect the image characteristics.
Dr. Romero has a question for you. Jorge?
Dr. Nazarian, congratulations on the great presentation. Just a few comments. Just going back to Luigi's point, we've always wanted to determine or characterize the substrate for atrial fibrillation, okay? But when we talk to the people here in cardiac, the radiologists, they're saying that we need actually a proprietary software to measure the scar, the delayed enhancement in the atrium because the thickness of the tissue.
Mm-hmm.
So I know it's so complicated, and you just mentioned that I mean, it's almost impossible these days, okay? So the question for you is, what would be the incremental value of doing cardiac MRI and characterize the delayed enhancement if we know that doing voltage map, endocardial voltage map in AFib it correlates very well with the delayed enhancement in cardiac MRI. First of all, I don't even know if you agree with that, but I do, based on a paper that I just read in Arrhythmia. So I don't really know what's the point in doing cardiac MRI if the voltage map is telling you pretty much the same information, and it's easier to do.
Yeah. Like I said, I think that the value of cardiac MRI for AFib right now is primarily in providing information about the pulmonary venous anomalies, about the left atrial size. In some patients, more and more, in some patients, we're finding other information that's useful, amyloidosis, things like that, where they're coming in with early atrial arrhythmias as a sign of something more. Using late gadolinium enhancement for the procedure in AFib patients, I don't think is prime time yet. I think that that's important to emphasize. I think that if DCAF2 is positive, that could change, right? Because it doesn't always correlate. I think that the studies that have shown that there's a good correlation between bipolar voltage and LGE are primarily, at least the ones that we published, primarily redo patients. In those patients, it correlates very well because ablation scar has low voltage and shows up on LGE. But de novo LGE, not from ablation, in my experience, doesn't correspond very well to LGE. So if Nasir shows that targeting LGE in DCAF2 improves outcomes, then there will be a clinical role. But short of that, I don't see a clinical role for it yet.
Preliminary data on, something we call scar homogenization of the left atrium. We did preliminary non-randomized trial when I was still a fellow in Austin, and it didn't improve the outcome. So this is a randomized trial. I don't know if it will, but it would be surprising to me because we believe the arrhythmia come from other area, not only from there.
I have my doubts too.
Last question for the sickness of time from Alan Kwan. Let's say for patients who have a device CID, who you wish to perform an arrhythmia substrate assessment, how do you manage the artifacts from the device?
That's a great
does
question.
this make the entire study non-viable, or do you cut area with artifacts? How do you manage this patient?
Yeah. So I'll tell you the most important thing in my experience is how thin is the patient. If the patient is thin and that device is very close to their heart, you have very high chances of not getting useful information. This is the one instance in medicine where being a big patient with a lot of tissue and distance between the device and the heart helps. If they do have a lot of tissue, the other thing that helps more than anything, more than any sequence changes, is to take some elastoplast tape and pull that device up to their shoulder with the elastoplast tape before you do the MRI. It'll help tremendously, more than any sequence changes. Beyond those things, there are sequences available. The wideband sequence helps reduce the artifact quite a lot. And there's actually some technology being developed for shimming when you're doing the MRI so that you can sort of shim to cancel the magnetic susceptibility artifact. But really the wideband is what's clinically the workhorse used. And my personal experience, tape it up, that improves more than anything else.
Do you even try doing mapping in these patients, or you don't add any T1 mapping ECV given the poor quality?
Yeah, the T1 mapping data, we've acquired it in some patients, but yeah, like you said, it's poor quality. It's hard to hang your hat on it. So I think it's not extremely useful.
So Dr. Nazarian, so Luigi, I'm sorry. So you're saying that tape the device a little bit high, but what about the artifact from the actual RV lead?
It's very small.
Okay,
You know, the
so
nice
don't
thing
care
is,
about that. Okay.
yeah, the in CT, the artifact from the lead is huge. The artifact from the device is small. In MR, it's the opposite. The artifact from the device is the problem, and the artifact from the lead is minimal. And it's really the defibrillators. The artifact comes from the transformer because it's a iron core to be able to transform that voltage from 2.78 to, or whatever it is, you know, to 800 volts. And that transformer is the problem. Whoever designs a transformer that doesn't have to have the iron core will have a good patent. If you think of it, let me know. We'll share the patent.
So do you use wideband at UPenn or at Hopkins before? Or you use it?
We use it at both, yeah.
So how can, because, you know, when Luigi with Chief Kumar and I train also there, and since I came and Luigi came here, we've been trying to start doing cardiac MRIs with devices, and it's been an uphill battle with the people from radiology, okay?
Really?
So,
we have it, we can do it.
So everybody can use wideband, or that's a proprietary?
No, it's you know, depends. What scanner do you have? It depends on the scanner.
We have 1.5 and 3 Tesla, no?
No, but I mean the platform. So
Philips.
Siemens, what's that?
Philips.
Siemens, yeah. So Siemens, they have a whip, right, for wideband, and you should be able to get it. I would contact Peng Hu. When I started doing it, it was around 2000. I don't know. I think Peng Hu wrote his paper. He's at UCLA, you know him probably. Peng wrote his paper in 2007 or 8, and he was very willing to share it. You know, they just shared the sequence, and I would contact your Siemens rep and Peng, and they should be able to get it done.
Okay, Saman, so on behalf of the Division of Cardiology here at Montefiore, thank you for being part of our lectures of CTMR on our cardiology YouTube channel. Thank you for spending the time with us, and please follow us on the next lecture very soon. Thank you very much.
My pleasure. Thanks again for the invitation.